Good morning, everyone. My name is Darius McLean. I am the Chief Operating Officer and Director of Programs here at the center. And I wanted to welcome you all to uh, today's Doctors In, which is focused on trans health. And to introduce, Michael, do you prefer Michael or Mike?
Both. I switch back and forth. Thanks.
So I'll pass it on to you. Thank you.
Thanks all. My name is Mike Danielevich. I am a family medicine trained, geriatric medicine trained, meaning I take care of folks over the age of 55, physician. I am currently in a hospice and palliative medicine role at Jefferson, finishing a second fellowship. And my interest is in the care of LGBTQIA plus older adults. So this is a topic that I think is really, really important to me personally. I'm going to pull up my slides. Before I do that, I want to say, although I'm interested in LGBTQIA plus older adult health, and especially the health of transgender older adults, I want to recognize that I am coming from this while I am a gay man. I recognize that I am a cis gay white man, so I can't speak on some of this personally. So when I do talk about these things, I'm talking about it from the perspective of a physician who has done a lot of work with patients, but not from a personal perspective. If anyone has questions or concerns or comments, I have 5 sections to this talk, and I want to open it up for folks to chime in either via the chat or via Q&A because we want to get as many questions answered as possible. So I am pulling up my screen now. The title of this talk is Equitable, Safe, and Competent Care for Transgender Older Adults, because that's really our goal, is to create care environments that feature all of these things. It's about more than just cultural competency or even cultural humility. It is about getting medical providers on board with caring for a group of populations that has historically not been served very well by the medical systems that we have. And I still can't say that we're perfect, but I think that we are working toward equity. So what I'm aiming to do today is to go over a brief review of how things stand right now, what the environment looks like for transgender older adults from a health perspective. I want to go through some common questions that folks have about gender affirming care, questions that I've gotten in clinic, questions that we've gotten from colleagues. I want to talk about appropriate screenings, both for cancer and other conditions. Talk a little bit about, as our transgender older adults age, some of the challenges that they've faced with long-term care. And then think about, as a hospice and palliative medicine physician, what are some of the things that we need to be thinking about as far as end-of-life considerations or serious illness. So at any point between the 5 sections, I invite folks to chime in. I'm happy to answer questions. I'll also have time at the end. So I'm going to start by talking about what things look like health-wise for transgender older adults. And I want to say that some of these statistics are startling, especially as someone who's interested in this. I'm not trying to paint a more bleak picture than it is, but I think we need to be realistic about some of the challenges. So I made this chart a couple of years ago with the help of one of our medical student colleagues. And we're looking at here, what are some of the disparities that transgender patients in general are looking at, and in particular, older adults. And these break down into issues in a couple of categories. Access to care. We know that unfortunately, the United States does not have a universal healthcare system. So that leaves folks, including older adults, maybe not being able to afford seeing a doctor. Back in 2005, which I know is a long time ago, 1/3 of transgender patients had no regular doctor. I would like to think that that's changed, but there hasn't been a specific study of that since. We know that transgender folks face certain health issues, not just because they are transgender, not because they are on hormones, largely because of access and equity issues, to the point where 1/3 of transgender patients in this area report poor health. Similarly, in the area of mental health, there are a lot of concerns. Again, a population that has been historically and currently marginalized, a population that has significant healthcare needs that are not being met in all cases. So that can result in some significant changes, some concerning coping mechanisms, and even attempts at suicide. And as far as discrimination, we see this both in the world of employment, as well as concerns about healthcare providers ourselves, feeling like and experiencing. So it's not just a fear, it is actually folks have experienced some forms of discrimination or bias in the world of healthcare, which I think unfortunately won't come as a surprise to many of those out there. When we look at specific health issues, like I mentioned, trans older adults are often reporting worse physical and mental health than their cis counterparts. A lot of these studies historically were not being done on transgender older adults. This was not a group of populations that was really getting sufficient focus. One of the bigger studies was done back in 2011 by a scientist. She was somewhere in the Midwest, I believe. And she looked at the lives of 6,450 transgender older adults. And at that time, a fifth of those people, think about that, over 1,000 people reported being refused care by their healthcare providers. 50% found that they had to teach their providers about transgender care. And we'll talk about why that is and how we're trying to change it. In general, trans older adults may often live with the fear of needs being ignored. These can range from things like hormonal care to even personal care. And we'll talk about that more later. So this is another study that was done back in 2019, and it looked at transgender older adults and said, hey, what are your biggest concerns with aging? And the first concern is one as a geriatrician that I see all the time, a change in independence, losing the ability to care for themselves. Number two, also as a geriatrician, really concerns me, in that 50% of respondents to this smaller survey reported that one of their biggest worries was having to go into a nursing home or an assisted living facility. We're going to review some of this later, and I can say it's concerning, but it also makes sense to me. Some of these other concerns are things that transgender older adults have to be concerned about that cisgender folks may not. Although some of them are more universally applicable to other LGBTQIA communities. Things like knowing who will claim or be given your body after you die, being buried in clothing that does not respect your affirmed gender, even having the wrong name put on your death certificate or your tombstone, having continued access to hormones. These are all very real concerns that transgender patients have. And it's why it's extra important that those of us in healthcare, not just those of us like me who have a special interest in caring for these populations, but all of us need to be prepared to address these. So back in 2020, one of the groups that I work with did a survey of primary care providers and staff at a major office in Center City, Philadelphia. And one of our goals was to figure out how comfortable do people feel caring for trans patients, and how comfortable do they feel offering specific aspects of care. So I'm not trying to make this a gotcha moment showing, well, people don't want to care for trans patients. We were trying to understand how can we target people's areas of concern and actually teach them. So back in 2020, folks noted that their comfort level is not always the same as their staff, that they have knowledge gaps when it comes to the care of transgender people and older adults. That hormone management is not something that a lot of providers and staff have received in their medical training, and that is only just starting to change now. You can see from this bar graph that people felt generally pretty comfortable communicating respectfully, using appropriate pronouns with people. That's the floor. When we looked at where people felt as far as prescribing hormone therapy, there's not as much confidence. So that's been part of what we've been working on, is changing some of this. Now, fortunately, major societies, things like the American Geriatric Society, are devoting attention to transgender older adults, to the point where we're actually doing a symposium on the care of LGBTQ+ older adults in general and transgender older adults in particular at the upcoming American Geriatric Society meeting in May. Fortunately, there has been a significant increase in research targeted at transgender older adults more recently. And most importantly, on the ground, these efforts toward the creation of equitable, safe, and inclusive practice settings are ongoing, including some of the work that my group has been doing at the Center for Healthy Aging at Jefferson, right here in Philly. So before I move on, does anyone have questions or concerns about anything that we've covered so far? Right. I'm going to move on. Part 2 of this talk is really talking more about transgender older adults and gender affirming therapies. My goal here is to do a brief overview of some of the considerations and answer some of the more common questions that folks have brought up to me. Now, gender affirming care historically was considered rather specialized. The reality is that any medical provider can provide gender affirming hormone care. The caveat to this being, most folks who are not actively seeking out treatment or who have not trained very recently have not gotten this training as part of their standard medical education. I can say that within our family medicine residency at Jefferson, as well as most other family medicine residencies that I've heard of, this is being integrated into the curriculum now, which is a good thing. And it's really reflecting the fact that gender affirming care is moving into the world of primary care. Whereas before folks had to go to specialized centers, we are really trying to create a world where anybody can go to any doctor and get these medicines prescribed. Now, there is a very easy resource guide here that is not so much for patients, but if anyone here is a medical provider or is interested in this, the UCSF Transgender Care Guide is fantastic. It can answer any questions that your providers may have. And I find that it takes a lot of the, when I was training, I relied on this a lot, and I still do, because a lot of the times our trans patients are coming to us expecting to have to teach us things. And, I always want to learn from my patients, but I also think that it's on the medical providers to learn this stuff and not just rely on the patient. So, common question. I've gotten this from patients. I've gotten this from other physicians. Is there an age at which gender affirming hormone therapy must be stopped? We know that as folks age, they often accumulate other medical conditions, and folks worry about that. Some of these medicines, if you look at the label of pretty much any medicine, you're going to find a lot of concerns. So it's a reasonable question that we'll get to. Another common question, is it ever too late to start with gender affirming hormone therapies? I've certainly seen folks who are older. I think the oldest person I've ever seen was over the age of 65 and had started with hormone therapy. And so folks ask, is there a point where it's too late? So let's go through it. Now, feminizing hormone therapy. When I use that term, I am talking about folks who are trans women. So folks who are on medicine like estrogen or spironolactone. Now, there is really not any good evidence to support continuing versus discontinuing therapy in transgender older women. What that means is societies have really not figured out the balance between risk of continuing therapy and risk of discontinuing. So this really has to be an individualized decision between everyone and their medical provider, because we recognize, those of us who care for transgender older adults, that gender identity is extremely important. And I consider hormone therapy to be a life-sustaining medication for many people. That said, there is some evidence that if a patient has undergone a gonadectomy, meaning that the testes have been removed surgically, you may consider discontinuing hormone therapy around age 50. Now, that is not a universally agreed upon thing. I will say that most folks are not doing that, but it is a consideration. It is possible. if we are thinking about initiating gender affirming therapy in older adults, meaning folks that age ranges over 50, over 55, however we want to call it, you may find that changes, the body changes are slower and that they may not be as dramatic as in younger folks. Theoretically, there may be a higher risk, not even degree, of adverse effects due to other medical conditions, which is why it's really important to have a provider who is caring for both your medical condition as well as your gender affirming therapy. So overall, we're really trying to take an individualized approach, weighing health conditions and expectations. And that's why I think it's really important to bring this up if you are even thinking of initiating therapy. Now, similarly, for masculinizing therapy, that is therapy for trans men, often done with testosterone, there is no age limit for testosterone therapy. Your providers will follow your usual labs, those being testosterone and blood counts. Now, depending on goals, some folks as they get older worry about their heart health. And the role of testosterone, how it interacts with cardiovascular health, is not really that well studied in transgender older adults. Some folks say, when might I discontinue therapy if I'm worried about these things? And the age that we start to think about that is around the usual age of menopause for non-transgender women, that is for cis women. That said, if you stop testosterone therapy, even if you are older, you do see some changes: reduced muscle mass, reduced body hair, and sometimes reduced sex drive. So again, in these cases, it's really important to be individualized, to recognize that withdrawing testosterone therapy will likely result in changes. Any questions about that? Now, obviously, this is just a brief drive-by of all these issues, but I wanted to try to cover a little bit of everything today. All right, hearing nothing, let's move on to screenings. I am a primary care doctor in addition to a hospice and palliative medicine doctor. The primary care side of my brain tells me constantly that screenings are among the most important things that we do in medicine. It is one of the areas, prevention is always better than cure, is my opinion. So screenings for transgender older adults are essential. They may get lost in the in many medical systems. And I say this because gender affirming therapy often takes priority. It is important, but we also need to be thinking about these screenings. And I'm going to go through a few specific ones in particular. The general idea when we think about cancer screening is that if an individual has a body part or organ and would otherwise meet criteria for screening, meaning not considering gender identity or gender expression, we should proceed with screening, regardless of hormone use, whether they're cis or trans. Now, I say this with some caveats because some of these screenings may be difficult for folks and they may cause some sense of gender dysphoria. Cervical cancer screening is a particularly difficult one in that it is performed via a Pap test, which often involves a pelvic exam. Current guidelines do recommend cervical cancer screening through age 65, with some caveats being, if there have been abnormal tests in the past, that can get extended. Trans men who have a cervix have a higher risk systemically of inadequate sampling and lab errors. Part of that is because of changes of hormone therapy on the vagina. It can be more difficult to do a pelvic exam at times. Part of it is due to a mismatch of sex and gender on the lab results. So it can be difficult for some labs have still not caught up, and they may get confused when they get a Pap specimen with a sex that does not match the gender. Cervical cancer screening can be one of the things that I find our trans patients do not want to do as often. And I think we in medicine have tried to make workarounds to make it less of a traumatic experience. Some of that can be self-swabbing. This can be a controversial topic among some docs, but there is an option to do a self-swab if folks feel more comfortable locating their own cervix manually. Sometimes we can also just have folks do a blind sweep with a small brush. I would say that is better than nothing as far as cervical cancer screening goes. Breast cancer screening is another one that we need to be thinking of. Now, typically, this does involve mammograms. Trans men who have not had a complete mastectomy, meaning no breast tissue remaining, should get mammograms. The guidelines from the US Preventive Services Task Force suggest until age 74, every 2 years. After that, it's really an individualized discussion due to risk and benefit of getting these mammograms. And not that the mammograms themselves are risky, it is more the question of what do we do if we find it in somebody who's older. Trans men with top surgery should get a routine chest wall examination from a provider. Excuse me, my cat is tearing up my couch. Hey, Luna, stop that. Sorry about that. But those who have had top surgery should get a chest wall examination from a provider. And again, that can be a difficult thing, so making sure that folks feel comfortable with their providers is essential. Trans women, due to hormone therapy, with estrogen in particular, may develop breast tissue. So trans women who either have breast tissue or who have been on hormone therapy for greater than 5 years should be getting a mammogram. And I think this is something that folks, including providers, often forget about. Prostate cancer screening in trans women. Again, something that not everyone is necessarily thinking about. The prostate, even with gender affirming surgery, meaning the formation of a neovagina, is often left intact. There has been some suggestion in the past that folks who are on estrogen therapy may be at lower risk of prostate cancer. And the reality is we can't say that for certain. It's kind of unclear. Screening for prostate cancer in general has been one of the more controversial topics in medicine. The guidelines have changed over the years, and the current recommendation is to discuss with provider. Because the test that we use, yes, it's a blood test. It can help us discover prostate cancer, but we can have some false positives, meaning it may find a prostate that's enlarged, and we can't differentiate that based on numbers. So there is the risk of a little more testing there to figure it out. So definitely something to be discussing with providers, starting generally at age 50. We start at age 45 if folks have a first-degree relative, so parent, sibling, child with prostate cancer. And we start at age 40 if they have multiple first-degree relatives, or we talk about this. We need to remember that prostate cancer diagnosis can affect sexual health, meaning that some of the therapies for prostate cancer can affect sex drive. And in some cases, the ability to continue hormone therapy. The reality of prostate cancer is that it is a difficult one in that most people, not all, die with prostate cancer and not of prostate cancer. So there's always this balancing act between we want to find the prostate cancers that are more dangerous, but we also don't want to put people through lots of testing for something that won't change. So I make no recommendation on this to you all today. I think that this is something to discuss with your own providers. And I think, Darius, did you raise your hand there?
I did. There were 2 questions in the chat.
Please, let's take a look. So the first question, is there medical guidance around adjusting hormone dosage as trans feminine folks approach the age at which those assigned female at birth develop menopause? There have been suggestions about this. There are not overall specific dose adjustment guidelines as far as there are not specific doses recommended. Generally, we titrate to effect, meaning are folks seeing the changes or seeing the gender identity that they feel comfortable with, and we titrate to avoid toxicity. That's why you'll notice that folks who are on oral estrogens, we check liver function, because oral estrogens are processed through the liver, and we need to make sure that the liver is working well. There are some suggestions that as folks approach the age that those who are assigned female at birth, maybe switching to a transdermal or a topical estrogen may be better for the liver. But again, I generally approach this as, if folks are not showing signs of toxicity, if folks are satisfied with their current gender identity and presentation, I don't make drastic changes unless I have concerns. The second question, can reducing T decrease overall energy? And in the case of trans men who are on T, it really depends. That is, again, historically, when we measured testosterone in transgender men, we are looking and targeting a range for the testosterone that matches that of cisgender men, or at least is in that range, and the range is very wide. So some folks do notice significant differences when we adjust doses, others don't at all. So again, I feel when I talk about these things, I feel bad almost saying how individualized everything is, because I wish I could give a blanket statement that yes, it will. And I can't give that specific of an answer. I think there's something in the, in the Q&A. Are there a number of doctors who are transgender working in the field today, or is that need for doctors being met? I would say that that transgender individuals are underrepresented in medicine. There are some in the Philadelphia community who are transgender and who are very involved in the care of other transgender people. There are some who are trans and working in other areas of medicine where they don't have as much interaction. I would say that the need is not quite being met. There are a good number of folks working in LGBTQIA+ medicine, including myself. But as I said, I am a gay cis man who is not trans. So I think there is a lot of work yet to be done on getting more folks into medicine, getting more folks as medicine adjusts and medical training has become more open and progressive, that folks feel comfortable making that transition in medical school or in their training. I hope that answers that question. I also wanted to talk a little bit about bone density screening. Guidelines from the University of California at San Francisco recommend a bone density screening test starting at age 65 for all transgender patients. Now, in our cis populations, you'll often see that this is differentiated between cis male, cis female. That for transgender patients, because of hormonal changes, UCSF essentially says, and they are not an official body, but they have some of the best evidence on this, that we should be at least screening all of our transgender folks over the age of 65. Screening, fortunately, is pretty straightforward. It is an X-ray. They have you lie down on a table. They run the X-ray machine right over you. It is not like a CAT scan where you're enclosed. It takes 15, 20 minutes. And what it does is it shows us what this image is here. And they can actually calculate based on how the bone looks, whether it is normal bone or osteoporotic bone, meaning it's kind of, the matrix is a lot thinner here. Now, I know we're talking about older adults here, but transgender folks who have had a gonadectomy and who have not been on hormone replacement for the last 5 years should also undergo screening regardless of age. Excuse me. Any other questions about screenings? So this next topic, I want to preface, this is a difficult topic to talk about and think about. It is one of my personal interests as I move forward in my career in geriatric medicine, is how are we working on this? And I think in Pennsylvania in particular, the Pennsylvania Medical Directors Association, which helps run a lot of it's a professional organization of folks who are involved in nursing home, post-acute care, so after hospital care, and long-term care. And they are interested in trying to work on creating safe spaces for transgender folks in long-term care. Now, it goes without saying, I think, for those who have been in a rehab or who have been in a nursing home, that these are predominantly cis-het places, cisgender, heteronormative. Transgender older adults have not historically felt comfortable, welcomed, or affirmed in long-term care facilities. In one study, 10% of folks actually reported that staff did not, either via refusal, which is the most concerning, or via repeated neglect to call them by their affirmed name or gender. And many of these folks were correcting people. There are concerns about folks' ability to live, present, and dress as their authentic selves, as well as concerns not just with staff, but for interactions with other residents. This is actually a news article from February of 2022 about a patient who was 78 years old. They were she is a trans woman. She was hospitalized and was needed to go to a rehab facility, which are often housed in nursing homes. And multiple nursing homes rejected her as a patient, due in part to the fact that she was a trans woman who was on gender affirming therapy. And I think that that is really just very disturbing. I think there are a number of potential reasons, not many of which I agree with. One, places may be concerned about the cost of therapies, because that is something that nursing homes take into account. Two, discomfort of staff, discomfort of other residents. This is just a huge, I have to say, this is a huge area that we in medicine need to be working on. Similarly, legally, I think there's a lot of advocacy that needs to be done to promote housing equity. 27 states, including Pennsylvania, as of a year and a half ago when this chart was created, provided no legal explicit protection against housing discrimination based on gender identity. And you see that kind of bi-coastal distribution of where places do explicitly forbid housing and public accommodation discrimination based on gender identity. So call your legislators. I think we have a good group of folks who are working on this now. I think, this is a difficult topic to talk about because I do get so disappointed with how the system has failed trans folks in the past and continues to in many ways. But there are potential legislative efforts. I think we're trying to come up with solutions here. There is a need for state and federal level protections, inclusive of sexual orientation and gender identity. This is becoming even more essential with some of the concerns going through the Supreme Court right now. There has been consideration of mandatory education on LGBTQ+ older adults in care facilities. I think the caveat to that is we need funding for those programs. Unfunded mandates are not going as far. There is a lot of talk, and actually this is where a lot of work has happened with the addition of LGBTQ+ inclusive efforts to area agencies on aging. Philadelphia has done a pretty good job of this overall, in that our city is reasonably progressive. Again, money always becomes the issue. And there needs to be advocacy for more funding for research on LGBTQ+ older adults in general. This is something that we are also working on. Any questions about post-acute or long-term care before I go to my fifth and final section? All right, one last section, and I don't mean to end on a downer, but I do think that it's important as a hospice and palliative care physician. I think that we do need to be thinking about serious illness and end of life. Before I move on, I think there's a question there. This is a very good question. Has the COVID epidemic brought additional specific health issues for the transgender communities that you are aware of? I would say yes, overall. I think that there have been a couple locally that I know has been a big issue. One is wait times. As folks went off and quarantined during COVID, some places, including healthcare facilities, went virtual only. Some places had very limited spots. For our transgender folks in particular, this has meant that, especially at some of our more specialized facilities in the area, the backlog was real after COVID. So that is a backlog of folks who are trying to initiate gender affirming therapies, who are trying to continue, as well as those who are trying to get screenings. So I would say that is one big area. Another specific area that I see among kind of globally among older adults, and I am certain that this is true among trans older adults and even communities like the Elder Initiative, is isolation became a really significant issue during the COVID pandemic. And I think we are just now starting to see how much that affected people. I think as somebody who believed in masking and quarantining, I think we are now seeing the effects that can have on people, especially older folks who rely to some degree on their communities to get out of the house and to do things. So those would be the two biggest. I don't have specific data to suggest cancer or to suggest that other things increased during COVID. I wouldn't necessarily be surprised if some of that is true, as folks delayed their routine care due to appropriate concerns about COVID-19. And I appreciate this comment from Shakina Rose about the Rust Belt Center for AIDS Research, Sex and Gender, beginning research on cisgender and trans women in several areas of care specific to HIV, sex, and gender. More work does need to be done. Are there nursing homes more friendly to transgender people? Another really, really good question. So this is part of what I don't have names right now to give you. I'm saying that to start. I recently applied for a federal grant to begin a more comprehensive training program to identify nursing homes that are more friendly and accepting, not just accepting, but also competent at caring for trans folks. So I would say keep your ears peeled for that over the next year. And I defer to Darius for the question about recording and slides, but I do hope that we can find a way to make these available. I want to say I appreciate all of these questions and the spirited discussion as always. So going back to serious illness and end-of-life preparations, important for everyone, but there are some specific things that trans folks need to be aware of. So the need for surrogate decision makers. And what I mean about this is, obviously, when we see anyone in a healthcare setting, I hope that that person is able to make their own healthcare decisions. There are certain times, whether it's due to cognitive changes, things like dementia, whether it is due to temporary changes, confusion or delirium, or medical status, it's not always possible for us to rely on a patient themselves to make decisions. And it's especially important for everyone, but especially trans folks, to have someone written down as a legally named surrogate medical decision maker, especially so if they're single or unpartnered, doesn't have children or doesn't want children involved, or doesn't want family members involved. Because then I say biofamily, because in the state of Pennsylvania, there is a very strict hierarchy otherwise. Meaning, let's say if I am hospitalized and I do not name my partner who's in the other room as my surrogate decision maker, it goes in the order of parents or children, depending on age, children over parents, then siblings, and then they go down basically a family tree level hierarchy. And that can be fine. I mean, for someone like me, I would be okay if they went and reverted to my parents. Not everyone has that level of comfort. Not everyone is going to get that level of affirmation from biofamily members. So important to name a surrogate decision maker. Similarly, it's important to discuss with that surrogate decision maker and to have it in writing that there is respect for gender identity. Otherwise, folks even after death may face what we call dead naming, or may be labeled with inappropriate pronouns. Third, as folks age or as disease processes advance, partly due to some of the concerns that we've heard already, A lot of older folks feel forced back into the closet, feel that they're not able to express their sexual orientation or gender identity appropriately and authentically. So as I mentioned, legal gaps. Unmarried partners or families of choice are currently excluded from the state surrogacy or next of kin. That does not mean that if you document it, you cannot do it. Meaning, I encourage everyone on this call and anyone who listens online or afterward to document a surrogate decision maker. That is my biggest point from this. I also recommend that trans folks especially put it in their healthcare power of attorney, what is called a funeral directive or a disposition of remains directive. This is a specific set of wording that goes through how folks want to be presented after death, what their pronouns are, what their name will be reflected as in the paper on a grave marker. We're trying to ensure that sexual orientation and gender identity are preserved and respected. Now, the nice part about this is advanced directives can get really confusing. They can be overwhelming. If you have specific concerns about it, I know that we always do a workshop here with the Elder Initiative every other year. You don't need a lawyer for this if you don't have one. You can talk to your healthcare provider, or you can go online and type in Pennsylvania Advanced Healthcare Directive, and you will find this form. This form has 3 parts. I would say part 1, if you do nothing else, do part 1 to choose a medical decision maker. I don't love this form because part 2 gets really specific about some really crazy things that don't always apply in the real world. But I encourage you to look through part 2, some of the things like ventilators and chest compressions and artificial nutrition, which is really hard to think about in advance sometimes. But talk to your person that you name in part 1 about some of what you would and wouldn't want to help them actively make decisions for you. And then in part 3, you sign the form. You get a witness and you sign it. And as long as you give that to your healthcare provider or bring it with you when you seek healthcare in a hospital or other setting, they have to respect that in the state of Pennsylvania. New Jersey has its own form if anyone here is from New Jersey. There is also a document that you can look up called the 5 Wishes that gets a little bit granular with some things, but again, counts as a legal document in the state of Pennsylvania. All right. So I want to wrap up and leave some time for questions, but I want to put home some key points. We've said this many times, transgender older adults have historically experienced challenges with health and healthcare. Major organizations in American healthcare are starting to pay increased attention to their needs. We know that there are no set age limits on gender affirming therapy, and I encourage everyone to be talking to their providers about that. Screenings are important for all older adults, but also for transgender older adults. We should be discussing those. And we should be thinking about special preparations for long-term care and end of life to ensure that wishes are honored and that identities are respected. I appreciate the engagement. I appreciate being here.
Michael, there was one question that I popped in there that someone sent to me. So they asked if the COVID epidemic brought additional. Okay.
I answered that one a little bit ago.
I thought so. Okay,
Yeah.
it just wasn't. It looked like it just came to me. Thank you.
I do see. Is there anyone providing training in completing forms like advanced directives? There are in the Philadelphia area. The Philadelphia Corporation for Aging (PCA) does have assistants that can do this. I don't have their number right away. Darius, do you know if William Way is still doing anything with this? I know a couple of years ago we were kind of helping out with some of these things, but I don't know what's happened with that.
Not since I've been there. Ed, have we been doing it specifically through AI?
If not, that is something that we should do. I know that last year one of my colleagues did a workshop on this. I think that we can certainly, if there's interest in that, we can do it again, because this is something. Darius, I can also make sure that you all get I have a ton of copies of that 5 wishes documentation in my desk at work, and I can certainly make sure that you guys get a set of that just to hand out if and when we go back to in person. That's what I thought. I thought there was a collaboration with Mazzoni.
Also, someone had asked about the webinar being posted. David is going to be posting everything to the webinar, or all the webinars that happen when he's back. Ed and I don't have the access to do so. In the back channel, I'm not sure how the slides go, but if you're able to share them with us, we can figure out a way
absolutely.
of getting them.
I'm happy to do that. And I see a question, is the area that I work in for Jefferson specific to LGBT geriatrics? So I am currently completing a hospice and palliative medicine fellowship this year. I am currently in the final stages of applying to Jefferson to do this work. So yeah, so long story short, it will be, assuming I'm in the final stages. So hopefully keep your ears peeled. We'll be talking more about that in the future, but I'm looking to start in August and really start welcoming folks and providing this care at Jefferson. The Center for Healthy Aging, I would say at Jefferson Geriatrics, is already one of the more culturally and medically competent places, I would say, because I have been working with them for the past 3 years. We've been doing trainings. We have folks over there who are already very interested in the care of LGBTQ plus older adults. And I'm hoping to be joining them pretty soon to really create a center. Thanks. All right, everyone. Well, I really appreciate you all coming. Again, the discussion. And I'm going to put my email in the chat here in case anyone wants to connect over any of these things. Feel free to shoot me an email. Obviously can't give specific medical advice, but I think I'm happy to talk more about these topics in however can be helpful. And yes, Cherry Hill area, New Jersey has done a really pretty good job with having multiple affirming practices. I know Jeff Cooper and Virtua, those are all great places that I'm hoping to work with in the future and kind of bring this work towards Center City too. Oh, and CHOP, the Gender Center at CHOP for the young folks, it's probably one of, if not the best in the country. It's really an impressive setup. All right, I'm going to head off to clinic for the afternoon, but feel free to reach out with questions or concerns, and thanks for having me.